Hello, everyone, and welcome to another installment of our educational lecture series from the Society for Perioperative Assessment and Quality Improvement, or SPACI. My name is Dr. Marinay Kaligi. I'm a professor of clinical practice at the University of Washington School of Medicine and the director of the Preoperative Medicine Clinic at the VA Puget Sound Healthcare System in Seattle, Washington. The goal of this educational series is to deliver short, high-yield videos that help healthcare professionals stay current on best practices in perioperative medicine. These videos are also meant to be practical and easy to use for teaching learners at all levels, whether you're working with medical students, residents, or other clinicians. Today, we're going to review the perioperative management of severe valvular heart disease. Valvular heart disease is more prevalent in women, and its occurrence increases with age, affecting approximately 10% of individuals aged 75 or older. Therefore, it is not uncommon to identify a new murmur during the perioperative cardiac exam, necessitating a preoperative echocardiogram to evaluate for severe valvular heart disease. Severe valvulopathy is associated with an elevated perioperative risk of heart failure, arrhythmias, ischemia, and death. The 2024 AHA-ACC guideline for perioperative cardiovascular management for non-cardiac surgery acknowledges the increased risk associated with severe valvular heart disease by including it as a risk modifier, which necessitates a team-based approach to risk assessment, perioperative diagnostic testing, and management. Therefore, if there is concern for the presence of a valvular heart disease, it is recommended to obtain a new echocardiogram in patients with an unexplored heart murmur. Additionally, a preoperative echocardiogram should be performed for patients with moderate or severe valvular heart disease if no echocardiogram is available within the past 6 to 12 months, or if the patient exhibits new or worsening symptoms such as dyspnea and exertion, angina, signs of heart failure, pre-syncope, or syncope. Aortic stenosis is classified as severe when the aortic valve area measures 1 centimeter squared or less, accompanied by a mean gradient of 40 millimeters mercury or greater, or a peak velocity of 4 meters per second or higher. This results in a fixed cardiac output, which increases the risk of hypotension, myocardial ischemia, heart failure, and sudden death. The 2024 AHA-ACC guidelines for management of patients with severe aortic stenosis requiring elective or time-sensitive non-cardiac surgery is illustrated in this decision flowchart. For asymptomatic patients with severe AS and preserved left ventricular systolic function who are scheduled to undergo low-risk surgery, it is reasonable to proceed with caution and careful perioperative monitoring. However, if the patient is to undergo elevated risk surgery, has left ventricular systolic dysfunction, or is symptomatic, then elective surgery should be postponed to consider aortic valve replacement if the patient is a suitable candidate. For patients who are not candidates for aortic valve replacement surgery, alternative management options such as balloon aortic valvuloplasty, minimally invasive procedures, or non-surgical approaches should be considered after clarifying the goals of care and engaging in shared decision-making. Similarly, if non-cardiac surgery cannot be delayed, a team-based and patient-centered approach is recommended. This approach should focus on optimizing preload, avoiding hypotension, and maintaining sinus rhythm perioperatively. Severe mitral stenosis is defined as a mitral valve area of 1.5 centimeters squared or less, or a diastolic pressure half time of 150 milliseconds or greater. This condition increases the risk of pulmonary edema, hypotension, arrhythmias, particularly atrial fibrillation, and left atrial thrombus formation. According to the 2024 AHA-ACC guidelines, patients with severe mitral stenosis, whether symptomatic or asymptomatic, especially those with elevated pulmonary artery pressures of greater than 50 millimeters mercury or new onset atrial fibrillation, should be evaluated for mitral valve intervention before elective non-cardiac surgery. If the surgery cannot be delayed, percutaneous balloon mitral valvotomy should be considered for those with favorable anatomy. However, for patients who cannot undergo mitral valve intervention before non-cardiac surgery, it is important to optimize heart rate control using beta blockers or calcium channel blockers as needed, and to maintain sinus rhythm to prolong diastolic filling time and improve forward flow. Additionally, perioperative invasive hemodynamic monitoring is recommended to guide management and reduce the risk of cardiovascular complications. Chronic regurgitant valvulopathies commonly present as progressive exercise intolerance, dyspnea, or orthopnea and are associated with increased cardiovascular risk during non-cardiac surgery, although they are better tolerated than stenotic valvular diseases. The risk is further elevated if concomitant left ventricular systolic dysfunction, pulmonary hypertension, or atrial fibrillation is present. Therefore, it is recommended to obtain echocardiography before elective non-cardiac surgery in patients with suspected moderate or severe valvular regurgitation to guide their perioperative management. Mitral regurgitation is classified as severe when the regurgitant volume exceeds 60 milliliters per beat, the fraction is greater than 50%, and the effective orifice area is zero point 0.4 centimeters square or more. This condition is associated with an increased risk of volume overload, pulmonary edema, and left ventricular dysfunction. Asymptomatic patients with moderate to severe mitral regurgitation, preserved left ventricular systolic function, and an estimated pulmonary artery systolic pressure of less than 50 millimeters mercury can reasonably undergo surgery with careful hemodynamic monitoring. Perioperative management should focus on avoiding bradycardia and sudden changes in afterload while maintaining adequate preload. However, elective elevated risk non-cardiac surgery should be postponed in symptomatic patients with severe mitral regurgitation to allow for optimization, including consideration of mitral valve repair or replacement in those who meet the criteria for valvular intervention. Severe aortic regurgitation is defined by a regurgitant volume exceeding 60 milliliters per beat, a fraction greater than 50%, or an effective orifice area of zero point 0.3 centimeters squared or more. This condition increases the risk of left ventricular dilation and heart failure, leading to myocardial wall stress, reduced coronary perfusion, hemodynamic instability, pulmonary edema, and arrhythmias. Asymptomatic patients with moderate to severe aortic regurgitation and preserved left ventricular systolic function can reasonably undergo surgery with careful hemodynamic monitoring. Perioperatively, it is recommended to avoid bradycardia to minimize diastolic filling times and to lower afterload to maintain forward flow while avoiding excessive vasodilation. However, elective elevated risk non-cardiac surgery should be delayed in symptomatic patients with severe aortic regurgitation to allow for optimization in those who meet the criteria for valvular intervention. In summary, for patients with severe valvular heart disease, a careful preoperative evaluation is essential and decisions should be made through multidisciplinary shared decision making. Symptomatic patients may require postponement of elective non-cardiac surgery to allow for intervention and optimization of their valvulopathy. Utilizing structured algorithms and team-based planning to guide perioperative management is highly recommended. And if you find that the surgical risk is prohibitive, consider alternatives to surgery. Finally, for patients who proceed with surgery, ensure that medical therapy is optimized and closely monitor the patient throughout the perioperative period. I would like to express my sincere gratitude to Dr. Nathaniel Smilowitz for his expert review and invaluable feedback, which greatly enhanced the clarity and accuracy of this presentation. This presentation provided an overview of the perioperative management of severe valvular heart disease. In our upcoming videos, we will dive deeper into more important topics, including practical ways to apply cardiac biomarkers in your clinical practice, understanding myocardial injury after non-cardiac surgery, and the role of postoperative troponin monitoring. Thank you very much for watching this video in our perioperative medicine series. If you found this overview helpful, please like and subscribe so you don't miss the upcoming videos. Additionally, please share any questions or topics you would like us to cover in the comments below. Our goal is to ensure this series is useful and relevant to you. Thank you, and see you next time.